But what would you say to somebody that was listening, having gone through it and understanding the health?
It is a long road, and you have to be planning for a marathon. This is not a sprint. I think that you grow better in systems that are built to support people. Patients come with burns, let's say a child. Most important thing is percentage, body percentage area of the burned area. In locations also, head and neck is a big problem. Airway is an issue. Now, small burns are not a big deal. You can do like wound care, dressings, and then they go home. We're talking about 1 to 5% burns, things we all experience in our life at one point. So high voltage electric burn is a problem because there's an inlet and an exit. This is where the electric current would go through your body. And a lot of times, if there is enough time, everything in that pathway could be destructed.
I'm Dan Metcalfe. Thank you for tuning into the Born SuperHuman podcast. I'm so proud of the guests and stories that we bring to you, and I know that you'll enjoy what we have ahead. Please like, subscribe, and follow. It really makes a huge difference in our ability to continue these conversations being brought to you. And if you feel the passion behind Born SuperHuman, please share it with your friends and family and leave a comment. I read every one. Now, let's get on with the show. Dr. Hisham, it's so good to have you here today. And I looked throughout so many different experts that I read about online, but your name kept coming up as a mentor to so many experts. But before we get to that and your plastic surgery, reconstructive surgery, the way you impact people's lives to give them back a sense of self and beauty, let's go back to you. Egypt, your place of birth. Tell us about you growing up.
Well, first of all, thank you so much for having me. I'm a great fan of yours, as you know, and I love what you do and everything you bring to the table. So an honor for me to be here. So let's talk about back home. So that's going back 25 years plus, right? So I was born in Cairo. I was raised in Cairo. I actually went to medical school in Cairo University. I finished my plastic surgery residency at Cairo University, biggest university in Egypt, basically. And then I was a faculty at the university for 2 years. And in order to do a full professorship, to become a full professor, you have to do a PhD. And this is when it started, basically, my, coming to the US and all this. But going back home was an incredibly rich experience. Growing up there, 70s and 80s were a very, 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 very different time, as you can imagine. No social media, no mobile phones, right? No internet. So we really had a life. So that was very exciting.
But as a young boy, what was your dream? Because obviously it sounds like you went to medical school very early. Was that what you grew up knowing you wanted to be? And what was that influence?
I think when I was a young boy, actually, I wanted to be an astronaut. That was because in the late 70s, that was the shuttle, when the shuttle went to the space, and we were all very mesmerized about it. It's like, oh my God, this is something we need to be part of. But then eventually, as I got into my education, I realized that I'm more into biology than into math. So I knew that I'm not an engineer. I knew I'm more of medical. And then it's almost like the way, and it's just step by step you're walking it. And it's funny, I very much remember the days I made the decision to go into first science, because that's how high school was divided in my time. You divide into science and literature, and then you divide into math and science. So I remember the days where I took the decision, I need to go into science, not literature. And then I took another decision. I knew I need to go into biology and not math. And then the third decision was I knew I need to go to medical school. It was interesting. It's almost like a road in front of you and you just have to walk. Very, very interesting.
Was there an inspiration or somebody that you looked up to and said it inspired you to make that decision, or how did you even come to it?
Reading. I mean, since I'm a single child, so I spent a lot of my time reading when I was young. So between sports and reading, this was my thing, and I would devour any book. I mean, even much higher than my level. I mean, my dad used to be like, "What? What do you want to buy? That's for PhD students." And I said, "Yeah, I just want to see it." And I started reading about the human body, about medicine. I was amazed by the discoveries of vaccines, discoveries of antibiotics, all this. So I really got into like, wow, this is very exciting. I want to be part of that. So I think that's how it started.
Did you talk about your dad mentioned he was, surprised at the level you were going to? What did your parents do? Was it related to the medical world?
Totally opposite. So they were both. My whole family is in politics. So they were politicians. They were journalists. They write books. My family was involved in the whole political thing in Egypt since the 1940s, basically. And my uncle went to prison with President Sadat fighting the British occupation. No offense, right?
July 4th, yes.
Right. Yeah, exactly. So anyway, so we have that background, and I thought that at one point I might do that, but then I realized, and my mom gave me a very good advice, and she said, listen, you could always be a politician, you can always be a writer, you can always be a journalist, but you gotta have a skill under your belt. Why don't you build a skill first? And if you find it in yourself that you want to be a politician one day, just be a politician. But get that skill under your belt first. And I think it was a great advice.
Yeah, let's talk about wisdom, right? When you look at your
Yeah.
parents and how you're brought up. So you go in there, were you ever interested in sports? Were you athletic or were you completely academic?
No, I played a lot of things. I played tennis when I was younger. I played handball, which is not very well known in the US. And then I played martial arts for a long time. I was into the black belt. I actually was training with the Egyptian national team at one point. But then again, I had another conversation with my dad because when you go into competition, these are rough sports, and I injured myself a few times, and one time I broke a rib, and so my dad said, listen, if you really want to, and this was medical school, he said, if you want to be a surgeon one day, I don't think it's a good idea to break your hand now. And I said, okay, well, maybe it's a good point. So this is when I kind of slowed down a little bit on that.
Yeah, I was going to say sometimes they say it's good to know what your patients are going through to be able to help them, but not in your case. It's
Right.
like you know the body, you don't need to experience it to understand it. What do you still compete in sports, or when I say compete, I'm talking about yourself. Do you still keep yourself fit and healthy?
Yeah, so I went through a time where I was extremely busy with medicine. So when you go into surgical residency, you don't sleep, basically. I mean, you are working sometimes 36 hours straight. You have enough time to go home and sleep on the couch because you cannot go upstairs. You're so tired, you just can't. And that time, unfortunately, you don't give your body what it deserves. And then you come into your 40s and you realize it's like, wow, this is not going well, right? Because then we start aging and all this. And then it hit me at one point when, and this was a few years ago, I started having high blood pressure and I started having high cholesterol. And I went to a friend of mine and I said, listen, why don't you give me some medication? And he looked at me, he said, no, I'm not. I'm not going to give you medication. You know what you need to do. Just go do it. And that's when I started, okay, what did I like when I was a young boy? I liked swimming, I liked martial arts, and I liked biking. I can't do martial arts now, but I went back to swimming and I went back to biking, and that was a game changer for me. And it got me, I feel better today than I was in my mid 30s probably. So that was great.
Amazing. I have this saying, the magic we seek is in the work we avoid. We know we should be doing it and we get swamped down. But it sounds like two pieces of advice that really changed your life came from your mother and then from your friend that said, you're made to heal, you're made to be healthy if you give the body what it, actually needs. What advice would you give to somebody then? Because I know you can't change the hours when you're going through medical school, the demand is there, the learning. But what would you say to somebody that was listening, having gone through it and understanding the health?
So it is a long road, and you have to be planning for a marathon. This is not a sprint. You still have to take care of your body. I mean, I probably could have done a better job when I was much younger, taking care of my body. I think I was just tired. Now the system is better now, so there's no these 36 hours straight works anymore. The rules change, so the maximum hours you can work in your residency now is 80 hours in the US. So that controlled things a little bit. So people have a little bit more time to rest and exercise and things like that. But you got to do that work-life balance, right? You got to take care of your body. You got to take care of your mind as well. You got to meditate. You got to pray. You got to do whatever gets you in the zone, as they say. Because otherwise, I think your body aches more, and then your mind is more tired, and then your mind makes your body more tired, and it's just a circle. And I know you're the expert on this, right? So you probably teach people that.
Yeah, I think the saying that comes to mind again is self-love is critical. It's not selfish. And we're brought up sometimes in society to told you got to give. If you're not giving, if you're actually giving to yourself and not someone else, you're actually selfish, or you should be doing more. And it's like when you're in a plane and they say if you're losing altitude and the mask comes down, put it on you first so that you can, help more people. And there's incredible doctors and people that are going to become doctors in the medical world, my mother included, who sacrifices herself for others. And you turn around and go, I wish you'd see yourself as your patient as well sometimes. You're in Egypt, you go and work in the biggest hospital at the time, in
Biggest university hospital,
the
correct.
biggest university hospital. At what point did you then say, this is my country, this is my home, I love it, but I've got this vision of going to America? Or how did that come about?
End of medical school. So end of medical school was very tough. The final years, the last 3 years of medical school in the British system is basically 1 year, and it's a marathon, and it's exhausting, and it's mental, and I felt at that point like, you know what I'm trying to achieve, I might not be able to achieve it there. And that took me to the next step, which is I went to a French school. So I went to a French Catholic school in Cairo for 14 years of my life, basically my whole education. So the first thing I did was knock on the door of the French system. So I took the exams of the French, and I went actually to France, and I did a small internship, something like that in Bretagne, in Rennes, Bretagne, which is a beautiful area on the coast. Very good people. And then in Bretagne, in France, I realized that I need to go to the US. And I started studying for the US exams when I was in France, which was interesting because I knew this is what I need to end up going to.
Yeah, it's great. Want to go back just for something you said. You knew you couldn't achieve what you wanted to achieve when you graduated from the university. What was it you wanted to achieve?
I think that you grow better in systems that are built to support people and to make them grow and go to the next level. And there's no question. I mean, Egypt. Let me tell you, I love Egypt, and I love my heritage. I love there. I go there twice or three times a year, and I have a lot of projects there. But there's no question in my mind that the American system, America is a very unique model, and it was built on all of us coming from everywhere and then going into this big engine and putting our best, but also the country give us its best. And then we become suddenly part of the system. And that's ingenious. And I don't think there's any country in the world that would give you this. You know, we all love our countries where we come from, but I think that unique formula of going in, giving your best, and then there are other places that you can give your best, but you're not going to get there. And we know that. And they say something interestingly, I heard when I travel a lot, they say that Europe is the past. I think America is the present, and now they talk about Asia being the future. So it's generations, right? Everything changes. So in my time, in the 70s and 80s, America was the future, right? So we'll see. We'll see how that would go in the future. But definitely, I think you can achieve a lot more. And it's not. I mean, America is not a country. If you think about it, I mean, you compare America to one country. I think America is a continent. Like it's like 50 countries together. So obviously opportunities are more, chances of growing is more than anywhere else in my mind.
Yeah, I think it's that cross between a support system and a competition within America who's going to continue to grow so no one really settles. Always exploring. One thing I love as well, because I feel the same coming from England. America has so many opportunities, but it's great when you can go back to your country and continue to grow what you've learnt. I think I'll never leave England behind. It will always be my heart, and I know you feel the same. I know you're also involved heavily back there with charity, a beautiful charity that you have, and we're going to talk about that in a little while. But you studied your medicine, you've now graduated, you've continued to study. What was the idea of where you were going to practice? What was going to be your main focus? And how did you get into plastic surgery and reconstructive? What drove you there?
So I believe that every step you do in life has a value. So although the French trip and the time I spent in France was not for the full future, but it gave me a huge insight. So I decided on plastic surgery in France. So in France, I actually went and I did an internship in the pediatric plastic surgery department. And then I watched both the pediatrics and the adult plastic surgeons operate. And then I said, oh my God, this is it. This is what I totally want. I love this stuff. And by the way, it was mostly reconstructive. It was not aesthetics. It was not facelifts and tummy tucks. It was more like heavy reconstructive, tough cases, helping people, stuff like that. And this is when I made that decision. I'm going to go back on one of your questions. I just remembered something one of my professors told me. So when I had the opportunity to go to the US, I actually went back to Cairo to get permission from my parents and from my professors there to get them. Is like, is it okay for me to stay in the US? And I remember one of my senior professors said, please go. It is better for us that you're there than you're here. You can help us a lot more if you're there. So, and I was like very enlightening. It's like, wow, that's true, actually, right? I mean, if we all stay where we are, well, it's great, right? But at the same time, some of us have to go somewhere else and help that old camp. So that was very enlightening.
Yeah, it really goes back to the days where your family, but someone has to leave the home to expose more that the family could achieve. It sounds very similar to what, again, great advice. I live in near Hollywood, and growing up in England, we never really heard about plastic surgery. It was always when you heard plastic surgery, it was the aesthetics. It's the facelifts, it's all the things that change for beauty or perception of beauty to look younger. I love hearing that you went into the pediatric side when you first saw, because I've got some very good friends who run the cleft lip
Mhm.
reconstructive surgery, which is so dynamic for children. It's beautiful. Do you have a specific story of a child or something you saw that made your heart explode?
So interestingly, that department was actually focused on congenital anomalies. So a lot of cleft lips and palates, a lot of urogenital also malformation. So kids with hypospadias, which is some abnormality in the male urinary tract, and they were fixing it. I think it was more in my residency, and I think it was the burn unit. The burn unit is a very unique experience. It is life and death, and it is probably cancer and burns are one of the two most tough experiences to go through as a physician when you rotate for the first time. Because for cancer, you do your shift, you go home, and you come back in the morning, and some of your patients are no longer here. And that's heartbreaking. And on the burn side, it's pretty much the same. But the burn side also comes with pain because obviously most burns are very painful. So these two life changing definitely, and sometimes it's hard to stay in the burn unit for more than 3 months because you get depressed after some time. So anyway, so these were really life changing moments for me when I experienced it the first time.
What's the process of a burn unit victim? And I'd love to focus on a child for now because it's so emotional and it's got to be the toughest thing because you want to put your arms around them and with anybody, take their pain away, but especially a child that can't fully understand. What's the process from the moment they're admitted in? When do you learn about the burns? Is it important to know how it happened? Because obviously a fire burn might be different than a scalding hot water. Take us through that.
100%. So patients come with burns, let's say a child. The most important thing is percentage, body percentage area of the burned area. In locations also, head and neck is a big problem. Airway is an issue. Now, small burns are not a big deal. You can do like wound care dressings and then they go home. We're talking about 1 to 5% burns, things we all experience in our life at one point. Now, when you go into 2025 burn percentage of the body area, that becomes a little bit tricky, especially in kids, and they need admission, they need IV fluid. The biggest problem is when you get the burn, the skin, which is the protective layer, is no longer there. So your body is not able to maintain the fluids. So it starts evaporating. So you get dehydrated very quickly. At the same time, you can have infections quickly because bacteria now can go through that. And then other systems also gets involved, especially in large burns, like 70, 80%, that becomes a big deal. Then they get admitted, whether to the unit or to the regular floor, depends on the severity of the situation. And then they go through the regular daily dressing changes, care of the wound, maintaining nutrition. Nutrition is another big deal in burns because there's a lot of breakdown of proteins that happen in their body, and then you need to basically compensate for that. And so there's all these formulas that you have to calculate, giving them enough calories and giving them enough fluids and taking care of them. It's a full ICU management. Now, the system in the US is a little bit different. Most acute burns are not run by plastic surgeons. Most acute burns in the US are run by general surgeons, burn units. The plastic surgeons handles the surgical part of it. Back home, we used to run both acute and chronic burns, so it was a lot of night calls and being on call and things like that.
Is it different how you approach a child? Because I naturally go straight to thinking of a firefighter, right, who gets caught up in a fire that they're there to save, and they become the victim of the fire and the burn, trying to protect people from going through that. Is the emotional approach to them different?
The biggest problem in children in general is the communication. I mean, in an adult, a lot of times you can have a full communication, get a full history, be able to, and then you can do that in a 10-year-old, obviously. But if you're dealing with a 2-year-old, that's a very different situation. You just have to rely on your clinical examination, on labs that's done, on what your knowledge, and then treat them accordingly. Um, Interestingly enough, we found that children are very tough and they can tolerate a lot. And it's probably just a gift from God for them to survive and be able to continue.
Brilliance of the body. It really is a miracle what we can actually overcome and face. I remember growing up back in England, there was a phase that came in with acid attacks.
Mhm.
And I never thought we'd be talking about this. I didn't know where this conversation's going, but it's fascinating talking and learning from you. People were walking down the street and they'd have acid thrown in their face, especially women, and
Mhm.
scarred either from a angry ex-lover or someone that they rejected, or it could be a religious reason. What is the difference between an acid burn and how you treat it and a fire or a scalding burn? Because I would presume the acid's going to burn deeper.
100%. Yeah, acids are very destructive. And as you said, same situation is usually a vengeance, someone trying to really inflict harm on someone. And especially if it comes in the face, sometimes it comes in their eyes, they can lose their vision. It's a big deal. So in chemical burn, it's called chemical burn, it's not related to the percentage, but it's related to the type of chemical burn, whether acids or alkali, and in the same time, the location of the burn. And you got to work very quickly and you got to counter it in a certain way to be able to minimize the damage of that. But yeah, now chemical burn is horrible. And similar is electrical burn. Electrical burn was also another very, very bad type of burn.
That's a great point. With an electrical burn, does it spread further through the body because of the impact? It's not just the contact point or the depth, but it spreads deeper and more wide.
100%. So high voltage electric burn is a problem because there's an inlet and an exit. This is where the electric current would go through your body. And a lot of times, if there is enough time, everything in that pathway could be destructed. So muscles, tissues, whatever. I mean, luckily, it could be just a short distance or it's very quick exposure, not a very high voltage burn. The other problem with electric burn, it can interfere with the electricity of the heart, and then people can go into VFib, and the heart is unable to pump. So that's another issue they can get through.
Yeah, people have to take care. I remember back in England, I was changing my bathroom and making it pine. I wanted to make it like Scandinavian. And for some reason, I didn't turn the electricity off, and I decided to touch the live wire at 240 volts with a metal handled screwdriver. And all I remember was hearing this bang and flying across the bathroom, hitting the wall. And then for about 3 weeks, I had the worst headache, my whole body. It was pain, but again, very lucky to still be here. So it's been a pretty heavy conversation so far, but
Right.
but it's fascinating because these are things we don't hear about except in the news that something happened. Give me a story that lights you up. Somebody that maybe you didn't think was going to survive, but with you and the team's work, they're back living.
To be honest with you, a lot of it is related to trauma. And it is just incredible the amount of trauma and the type of traumas you see when you work in the trauma. And this is before plastic surgery. This is when you do general surgery, you get involved into these traumas. And you talk about the car accidents and people who get really unlucky or people who get shot, people get stab wounds. The funniest story I'm going to tell you is So I'm on call for trauma, and then this couple come to the trauma bay, and basically, um, the man has a stab wound to his chest, right? And the girl has a stab wound to her thigh. So the story is that they're dating and he forgot her birthday. So apparently they got into a small fight. She grabs a knife and she hits him in the chest. You would think that hitting in the chest is a pretty serious deal, right? Because then, I mean, it's close to the heart, you can die right away. So what happened with him is he had a little bit of air around the lung. We put a chest tube, watched him overnight, and it was not a big deal. Now, when she stabbed him with the knife in the chest, he actually grabbed the knife and stabbed her in the leg, thinking that it's easy, it's just muscles, it's not going to hurt her that much, right? So, guess what? She was very unlucky. It hit the artery. So it was exactly where that artery is. And then it cut the vessels. And then she had to have like extensive vascular surgery, vascular repair. Otherwise, she would lose her leg. But the crazy part about it is that he had his chest tube, she had her overnight surgery, and now I come in the morning to round, and guess what? He left his room and he's sitting by her bedside holding her hand. And I was like, what are you guys doing here? You just we're about to kill each other. But so anyway, it was crazy, but I mean, I guess some people, when they get very emotional, they can get into that kind of stuff. But they both survived very well. They both left the hospitals, and who knows? Maybe they're married now. Hopefully, they don't get into this activity again.
I was going to say, if they're married, I hope he doesn't forget the anniversary.
Exactly.
One thing. Yeah, let's hope there's no guns or anything around as well. So you come over to America. You're now engaged in growing the education, both for yourself, but not challenging the system in a negative way, but with your smarts, growing it. What more could we do? What was your path from that point to then opening your own businesses down in, Newport and Santa Monica, I believe is the other one?
Correct. Yeah, it's a very long way. So we started basically by going into to do my PhD studies and research. So my first 2 years were doing a lot of research papers. We even invented some instruments, surgical instruments, things like that. We got grants. So I was very involved in research when I was much younger, and that path would get me into the fellowship and residency of the U.S. So I was young enough, as you said, we finished early back home. So when I came to the US, I was about 27, 28 years old, which is pretty much the age where medical students finish in the US. So and another great advice I got from one of my mentors in the US, and he said, listen, I don't think we could take you as a junior attending, right? And you could do a small fellowship and go from there. But I think you're young enough that you should go through the system completely. And we'll give you some credit for what you've done before, which would happen. So I did general surgery, I did plastic surgery, and then I did a fellowship. And it took, a lot of time, was a lot of effort, but it was well worth it. Because American system is extremely different. It's just a totally different system of doing things. It's a very practical system. It's very clinical, even different than Europe. Europe is a very studious type of system. So, I mean, Egyptian system is a British system, basically. So we used to study a lot. Like if you take a medical student in Egypt or England, they're smarter than anyone. They can tell you science like no. But then you compare them to a medical student in America, that medical student can do more things with his hands. He can treat things, he can do things. So American system is a very practical system. So anyway, so it was fantastic for me to do that. Took another 7 to 8 years of my life, but it was totally well worth it. So that was until I finished my whole fellowship training, things like that, and then I become what they call board eligible, basically, which is kind of the end of the road. Now, the second part would be, what do I do next, right? So I was totally into academics. So my plan was always to stay at the university, have my own lab, do my clinical practice, things like that. But things happened, and things happen in life that kind of affect your way. And when we say sometimes, I will never do that, I learned to never say that, right? Because trust me, you'll change. And something big happened. One of my big mentors in the US passed away. And actually, he took his own life. And that was a game changer for me. And that was one thing that changed my perspective on many things. And I decided, you know what, I might need to be somewhere else. I need to start in a different place. I need to build something new. And then I met my wife at that point, and she's a California girl. First time I told her, I said, okay, we will get married, but one condition, we will never come to California, right? So that's another never, never say never, right? So
Where were you at the time? Where did you meet her?
so interesting. I was in Atlanta, She's from San Francisco. We met actually in Orange County in Huntington Beach in a wedding. And then we kept dating long distance for some time. And then we got married eventually. And then she moved to Atlanta for a year and a half, 2 years with me. And then when we decided to move, it just made sense to go back to California. You know what I'm saying? It was just, we have a lot of friends and family and things like that. So it ended up there, here again. So that's another thing I said I would never do. I ended up doing.
And when you moved back to California, then did you have a location to go to continue your practice? And where was that? Was that because if I read right, you worked as a professor of education at UCLA?
So the first step was I joined a group, a private practice group in Orange County, and at the same time, I did a part-time education at UCLA. So I was what we call a clinical attending, which is not a full-time position, but then you have your schedule, you go on certain times, and you teach the residents and things like that. So that was great, and I've done that since I did it for God 2005 until maybe 2023 or so. So I did for more
Wow.
than 15 years. Yeah, I was driving from Orange County to LA, but it was great, and I made great connections, wonderful people, and I learned. You know, when you teach, you learn. By the way, you learn a lot also. So that was great. And then I went and I opened my own practice in 2007, and so this is when I start my own thing, and that was Newport Beach, and I'm still in the same area.
Yeah, it's a beautiful area down there, certainly. It's great. Let's go on to people's perception, because I've actually come and visited you, and your office staff, your location is beautiful, but the way you talk with people, the way you care about people is, for me, unique. It's a genuine, it's not a business. It's, I'm here to help support you, which makes sense going back to your start and working with children and working with people on reconstructive for life rather than beauty. But I know you cover so many gamuts. What's the misconception that most people think when they come to visit you or they don't want to come and visit?
Luckily, a lot of people are well read. So by the time they come to us, they already talk to people and they read things. So that's a good thing. But in the beginning, there is a lot of things about that plastic surgery can do a lot more than it actually can do. You know, some people would come and bring you a picture of Tom Cruise and says, "Hey, I would love to have his nose," or "I would love to have." It's like, well, guess what? You can't have that, but I'll tell you what you can have, right? And it has to be a good agreement between the two. Is that what is expected, what is possible, and what we can actually achieve. And I think it's always fair to tell people, listen, I would love to do what you want me to do, but it's not feasible. I don't think you can do that. And sometimes I even go, the more you get older, the more you get actually more assertive. And I come to the point and tell people, listen, you don't need surgery and don't let anyone do surgery on you because you don't need it, right? Don't do that. Um, and I've been very lucky that people actually, a lot of time, they listen to that and they actually appreciate it. And sometimes I tell them, I'm not here to take your money. This is not about money. This is totally about me doing a good service to you so you're happy. So 10 years down the road, we meet on the street, you're going to say, you know what, this guy was fair to me and he did a good job with me. And that's what matters in my mind.
Well, knowing you well, it's more than fair.
Thank you.
Yeah, without a doubt. How much of this is psychological? Because it sounds like you talk to people and find out what's the need, why is there the need? What sort of questions should people be asking themselves before they come and see you? And is there a point they should actually go to a therapist to deal with issues rather than the external? At what point does that change?
I think a major question is why I'm doing this. You know, what exactly is the reason we're doing that? Is it something I'm doing because of myself, or it's something that I'm doing because of someone else or another perception? And we try to get into these discussions and make sure that we are very clear about what people are trying to do. And there's another aspect, which is an extreme aspect, which is people come to you and says, you know, I want something that is completely unnormal, which means someone who looks great. And we have this, by the way, people who come and they are like models and they come and says, I hate my body. I hate myself. I cannot stand myself. I cannot get in a bikini. And you look at them. And now this is something we study in medicine. And the studies say that you don't touch these patients because these patients don't need plastic surgery. As you said, they need therapy. But I also learned to be frank with them and tell them, listen, you understand that you're a 9 out of 10, right? And the reason I'm saying this is because there's no 10 out of 10. God, there's nothing called 10. There's always 9, and you're a 9. And I'm telling you this from a plastic surgery standpoint. And I found this to actually work. When some people need validation, and maybe because they don't get validation at home, maybe they didn't get their validation during childhood. So that's missing. It was not, the parent did not give them enough love. They did not give them enough confidence in themselves. So they're always missing this. They're trying to find it in something. So they come to a plastic surgeon thinking that, oh, he can make me a better looking body. Guess what? God make you a great looking body. You don't need me, trust me. So that works. Now, some people you can't. Some people are totally blocked and they said, no, I know, I want to do more surgery. And this is when I say, I'm not the guy for you. And my personal advice, don't let any guy do your surgery. You don't need surgery. But you mentioned a great point. Plastic surgery is always this psychological component. And if you don't study it well in the beginning, whatever you do, whatever good results you do, it's not going to work. And they're not going to be happy. And that's a problem.
I think that's where we see the obsession side that comes in. Because I love what you just said. It's beautiful looking at the person and what's missing, which can't be replaced with the external. But we all know the TV show Botched that goes on. And I think when you look at that, you're like, how could something be done so badly? Is there enough of education or restriction within the plastic surgery world that limits people, literally destroying people when you look at it?
So great question. And I've been honored to be a reviewer for the state of California for medical legal cases. And I get cases referred to me to evaluate and look what happened and why this is wrong and is this right and wrong. And there is a continuum between malpractice, which is doing something outrageous that no one in your community would do and would be a deviation from the medical practice, basically, and having a complication. So these are two different things. Now, having a complication is you do surgery on someone and they have an infection, or they have a bleeding, or they have a wound separation, things like that. And it could be more. That is a complication. It was in the norm of plastic surgery. It's well known. And if you're a good, competent surgeon, you'll be able to fix it and you'll be able to address it, take care of your patient, and get them to where they need to be. Now, if you do something totally outrageous, now, is it by mistake? You didn't have enough training for it? Or you just made a mistake, and mistakes happen. I mean, me and you, we heard all the time of the best hospitals in America, and they took the wrong kidney, right? The best place, and they did that. I mean, these are wonderful places, wonderful people, very smart, but there was a failure somewhere. Failure in the system, failure in personnel, failure in judgment, decision making. That day, something wrong happened. We're human, and mistakes can happen. I think medicine got a lot better, and we learned from the aviation industry. So aviation industry, as you well know, they managed to really, really train people to avoid catastrophes like the one that happened in Spain in the 70s. And they found that you have to minimize human error as much as possible. Aviation had simulators for a very long time. Medicine did not. When I was doing my PhD, I was working on some of the project with Georgia Tech about having medical simulator. So you actually go into a simulator and simulate doing surgery. Mm-hmm. There's a lot of that now. So surgeons are better trained. They go through different scenarios to avoid making actual mistakes. Are mistakes still happening? Yes, absolutely. Some of it could be doing something outside of your zone of training. So if you're a cardiac surgeon, you need to stick to cardiac surgery. If you're a plastic surgeon, stick to plastic surgery. I get sometimes some people telling me, hey, can you do this? I said, not my training. I might be able to do it, by the way. It's not hard. But it's not my training. This is not what I trained to do. I should not be doing this. There's another guy who spent his life training to do this. You need to go to him because you'll be better served. So I see mistakes when people cross, gynecologists are wonderful people, but if you're not trained in plastic surgery and you try to do a plastic surgery procedure, it doesn't work. Same for me if I try to do a GYN case. Well, I'm not a GYN. Why should I do that? So I think this is where mistakes can happen. And as you said, it could be catastrophic.
Does it happen? Because again, we know there's an obsession when people go beyond a certain point. Michael Jackson, who I was fortunate enough to meet and he came and saw what I was doing and stuff, went extreme. It became so, and I know where it started. It really started after he got his hair caught on fire shooting the Pepsi commercial. And he got third-degree burns from that. And there's a whole nother story we can talk about at some point about how that was the beginning of his decline, really. But if somebody won't do it people are so obsessed they'll find someone that does. And if everybody says they won't, they leave the country to go and find someone that will do it. Ethically incorrect for the doctor. But again, people are motivated by different reasons. How often do you see people that have gone overseas, got something done because they said no, and now you got to go corrective?
It happens a lot. People do it mainly for cost reasons. Obviously, healthcare system in America is expensive, and it costs a lot more to do surgery here than in Mexico or Egypt or many places. Europe is expensive still, probably like the US. So people travel and do things. They get a trip out of it, and then they get a procedure, right? And they pay 20% of the cost. The problem is, I have no doubt in my mind that there are wonderful surgeons in both all these countries, Mexico, Asia, Egypt, everywhere. The problem is sometimes it's not in the surgeon, it's in the system. And the system might not give you the whole support. So people go do surgery and then they have an infection, for example, or they have a wound separation, or they have this. The issue is you're no longer in that country. You're back home. Now you want to go to another surgeon to fix this. Some people don't want to take that complication because once they take it, it becomes their own, right?
Right.
Now, I don't think this way. I think that if someone needs help, they need help, and we should try to help them as much as possible. But I tell people, think well before you try to go somewhere else to do a procedure by saving $2,000 or $3,000. Is it worth it really? Because you might end up paying a lot more to fix it. Now, having said that, some cases work well and people do well and they're okay with it. But the problem is, if it doesn't work, then it's very costly, both risks, health, and money.
The first time we began to notice plastic surgery for enhancement was breast enhancement. And it was great to begin with, and then we began to see some of the failures from either lack of experience and seeing what really happens within the testing. And one of the things that I love about you is how you help with breast cancer and the reconstruction. I know you do a lot of donation of your time to help women feel feminine again, going through the trauma of maybe losing one or two breasts, the mastectomy, all the different stuff, and you give it back. Take us more into the impact of breast surgery and what got you to realize how important this really is.
So after all these years, 10 years ago, I decided to focus my practice on two things. One is breast, both breast cancer and cosmetic breast, and also facial aesthetics, where my fellowships were exactly, because I did an oculoplastic fellowship. So breast cancer is just one of these things that in my mind advanced so much from the 1970s until today. And I give a talk, and I give it in so many countries, about where we were in the 70s in breast reconstruction and where we are today. And when you put side by side, it's just incredible. Some of the mastectomies and reconstructions that are done today in America and everywhere are almost similar to that patient before having a mastectomy. And sometimes it even look better than their original breast. And I don't think it's just advancement in plastic surgery, but it's also advancement in techniques in oncology. So the way the breast itself, the mastectomy is done more conservatively. So you maintain the skin, you preserve the nipple areolar complex, you add to all that. Makes a huge difference, when you do that. So breast cancer is amazing. When I was in medical school, we used to call breast cancer the disease of old age. Or it used to be called, actually, the British in Belly and Love, which is a very famous general surgery textbook, British textbook. It's called the disease of nuns, and the reason is they're much older, and then they don't get married, they don't have kids and all this. Nowadays, this is not true. I can tell you that my breast cancer patients are 27-year-old, 29-year-old, married with kids, or actually that sometimes it comes during their pregnancy. So more and more, the age of breast cancer is getting younger, which is a problem because it becomes a social issue, because that person still have 40 years of life ahead of her. And as you know, breast is a very important part of the female body. And if you ignore it or you don't correct it properly, it's a huge psychological problem for them, for their marriage. It's end up being a problem. So advancement in breast cancer and the things that brings happiness to me is when I see, I'm old enough now to see my 15-year-old follow-ups on my 17-year-old follow-ups, breast cancer patient coming back to me and says, "Hey, Dr. Seify, you did my surgery 17 years ago. I'm cancer-free and my breast looks great. Look at how it is." And I always take pictures with them and I say, "I'm proud of you." And so I think major part of plastic surgery is breast reconstruction. And breast reconstruction allowed me to do complex cosmetic cases for breast. So I get a lot more complex breast cases, cosmetic cases, which had multiple surgeries before and they failed or had some issue and they need to be fixed because I have that reconstructive background, so I can do this. When I was much younger, I used to get more of the fresh breast augmentation, 21-year-old wants just the breast aug. Now I get more of the person who had 10 surgeries before and now they needed to be fixed, which I love, by the way. So I'm very proud that I'm part of this in my practice. Love that.
That's beautiful. What's the emotional change for a young woman or an older woman? It really is, I think it's kind of the same because you're dealing with life and death potential in there. So, two questions. Why has there been the growth of breast cancer compared to the 70s, where it's much more prevalent? What's your thoughts on why? And then what's the emotional change that women go through to get to that final decision of I'm going to have it done and the post?
So two things I think happened over the years. One, we had better diagnosis. So when I was back home, I used to see patients in stage 3 and 4, basically very terminal cancer. Now we catch cancer before it becomes cancer, like a 0 stage, basically, a DCIS, something like tiny, small. But guess what? If you leave it, it's going to continue to be a big breast cancer. So we catch it early, which means the patient is younger, obviously. If you wait, it's going to be at stage 3 and stage 4. Number two, definitely environmental factors. Definitely the food we eat, the pollution we have. These definitely affecting our capability of developing cancers, and breast cancer is one of them, I think. In terms of what they go through, it's interesting. I see very different types of people. I see the person who is very a believer, and it might not be religious, by the way. It might be just believing in the good things in life. And some of them are religious, and they said, listen, you know what? It's one of these things. It's cancer, could have been a car accident, could have been, it's just life gives you good things and bad things. And this is just one bad thing, but that's okay. I can deal with it. And I love this mindset. And I tell them, you know what? If you have that mindset from the beginning, I can guarantee, not guarantee, but I can tell you that you're probably going to do well. You're probably going to be fine, and probably your cancer is going to be, you're going to overcome it. The other type are the ones that melt down with the diagnosis. Some of them, interestingly, get a guilt feeling. I did something wrong. That's why I have cancer, right? And that's a very, very negative way of thinking. And again, it comes back to the discussion about childhood and some of the things, values and things that you heard when you were a child, and then it kind of lived with you. And I spent time with them. I said, no, that can happen to anyone. Trust me. That does not mean you did something bad, you're a bad person. It just happened. And guess what? People do extremely well. And we have enough patience now that some of our patients are willing to talk to others, like people who went through it and they healed and they're cancer free and they had reconstruction. They talk to the newer ones and they tell them their experience and they help them basically hold their hand through it. So that really helps a lot. And then there's a lot of normal people that just said, I just had a medical condition and it needs to be treated. And they get depressed a little bit. Family support is a big deal. When someone comes to the consultation with their husband or significant other, their kids, I say, wow, this is good. These people are well. When someone with cancer comes by herself to her consult, I worry because that means they don't have enough support. And that could be an issue because dealing with something like this, you need people around you. You need loved ones, you need family, you need friends. If you're by yourself, that's going to be tough. So it's tough. It's definitely a tough diagnosis.
My sixth pillar of the seven pillars of health is mindset. And it's fascinating how people think of mindset relative to sports or relative to taking on a challenge that you've really decided to go and take on, right? Okay, I'm going to do it. But fascinating how you bring up the mindset approach to health. And when you're going through something, is it really that determining in the potential of success?
100%. I can see it from day one. When patients from the beginning who have breast cancer, they start complaining about, will I have a scar? Will I have pigmentation? Will my breast look different? And I said, listen, we need to put things into perspective. And the fact of the matter is, yes, we have cancer. And you know how when we talk to people, the first thing is acceptance. You got to accept where your reality is. If you don't accept it, if you're in denial, it will never work because you just live somewhere else. You got to accept, okay, I got cancer. What next? What should I do? And part of it is, guess what? It comes with circumstances. It will come with a scar. Yes. It will come with surgery. Yes. It might come with chemo. It might come with radiation. It doesn't matter. At the end, you're going to be fine. And that should be the mindset. The mindset is not, am I going to have a scar? I worry about these patients because I know that, oh, this is going to be a long way. Because if you're worried about having a small scar, what are you going to do if you have chemo? Then your perspective is sort of anyway. But a lot of people end up doing fine. And God, I think at the end of the day, give them calmness and something to be able to fight this. And there's this saying that we say is that when God gives you something bad, He also gives you the power to manage it. And that's just how it works, I guess.
Yeah, I love that. It's great talking to you because I can actually say I was taught that denial is only a river in Egypt,
Yes,
and
yes, I
that
love
we
that.
accept everything else because I look at everything that happens to us is a gift if we wrap it correctly. How often do you turn around to those patients that don't have the support or those that do and advise them to have a therapist go through it with them?
It's tough. It's a very sensitive issue, and people get a little bit kind of sensitive about this, which is like because you don't want them to feel like I'm not crazy, right? But we say it in a small ways, like who's with you? Who's going to help you after surgery? This is how I get to know their family support. So who's going to drive you to the hospital? This is what I get to know what people is. When people say, "Oh, my husband and my kids," I was like, "Okay, you're fine. You know, you're not gonna have an issue." When people say, "Let me think, I might find a friend," it's like, "Oh, that's a problem." Because if you don't even think about someone that can drive you to when you're having cancer surgery. That means you don't have enough social support, and then you might need to talk to someone about it. Some people come to me actually and says, I feel depressed, and this is when I say, "Would you like to talk to someone?" And would you? And there's a lot of supports, obviously, and that can help with this for sure.
I know when people go through alcoholism or drug rehabilitation and they have support groups, do they have that for women that are going through that you can actually go and join?
Yeah, societies are very good in that. There's a great society support for breast cancer patients, the American Society of Plastic Surgery, which is I'm a member of. And they have these group supports. There's group supports online. Every practice has their own mini group support from previous patients who can help. Hand holding from the staff. It is a lot of good support, to be honest with you. The tricky part is the patient wanting that support. Some people don't. Some people decide to take the denial part.
Right.
That's hard.
It's got to be so tough because we don't know how people suffer. One thing I've learnt over the path of Born Superhuman is people would prefer to ignore it than actually face it and correct it. And we're talking about the approach to health and wellness. And yet they cry alone. And that outreach is actually a characteristic where someone says, I need help, I'm willing to get it. I'm not weak, I'm actually getting stronger because we know two people lifting a log is going to be much easier than one, and we can carry it together. When breast augmentation or the start of seeing breast implants come in, it was really silicone or saline. And people started off with going with silicone to begin with. And now there's been this movement of after 10 years, you have to have them replaced. And I got some friends that had it and didn't get them replaced, and then they leaked and create another potential catastrophe. How's that changed now and from when it first came out, obviously with education knowledge and product ability? And what would you say to women that when should they get those changes made?
So definitely the product improved. So the first generation of silicone implants were much weaker. They definitely leaked a little bit faster than now. Now I think we're in the fifth generation of breast implants. Silicone implants are solid implants that are the basis of implant reconstruction for breast cancer. They're also the basis of cosmetic breast augmentation. Now, saline implants are also good implants. They became popular during the time the silicone implants were banned, like 15 years ago or so. So a lot of people had saline implants. They're also good implants. They're just a little bit artificial because they don't give the same feeling as the silicone implants. Um, I think I tell my patient if it's not broken, don't fix it. Most patients after age 35 or 40, they get mammograms, and a lot of times, if there is a rupture in the implant, it might show on mammograms, although it's not the best study for rupture implants. Um, I have never seen an implant that's more than 20 years that's not ruptured. So to me, 15 to 20 years is kind of the sweet spot. And I tell people when they ask me, will this ever rupture? I said, it's man-made. One day it will rupture. I promise you that. The question is, most people are fine with it. The people who end up having problems are the people who keep their implants for 40 years or 30 years or 50. I had 50-year-old implants that I took out. I was like, of course it's ruptured. I mean, imagine driving a 50-year-old car that you never serviced. Guess what? It's gonna break one day. Um, so there is an interesting movement now away from breast implants. So that's another movement for people who had breast implants many years ago. They come and they want to take them out for some good reasons. It's called breast implant illness, which is an illness that has no labs. Like it's hard to measure a blood level and know that you have breast implant illness. But these females come and says, I feel tired, I lose my hair, some of my memories sometimes. And it could be related and it could not be. The patients I've done who come with this, when you take the implant out, they actually get better. And they come back and say, I'm happier now without the implant. Now, it's nice if they still have a lot of breast tissue, like native breast tissue, because then they still look fine. My issue is if someone has no breast tissue and they had implants all their life, and then suddenly they're going to go from a C or a D to nothing. That is a big psychological trauma if you're not ready for it. And I spend a lot of time talking to them. It's like, you know, are you ready for that? You know, for the last 30 years of your life, you stand in front of the mirror, you have a C cup. Tomorrow, you're going to stand in front of the mirror, you'll have no breast at all. Are you ready for that? Are you okay with that? Or the other option is we can go with a saline implant that's smaller, right? So we kind of get in the middle of this. And again, there's different type of people. And some people say, yes, I'm ready for it. Some people say, no, let's put a small implants. And at the end of the day, it's a very personalized care. So it's not a plan for everyone. You know, everyone has their own situation and you have to treat them accordingly in mind.
With that being said, when a breast implant ruptures, the first is I need this out of my body. But you said a mammogram, sorry, may not reveal that there's a tear or there's a slight leak. Is there a test that women could do that would reveal it? How often should they have it done, if there is? And because a lot of it's psychological, the emotional support of I feel good, when you begin to fear because one of your friends or you hear it on the news, and we know on the news things can be very exaggerated as well because of the drama. And then how many women turn around having had a leak and said, I will put another one in because now they've had adverse effects?
So many, by the way. The majority of people actually they exchange their implant. They don't take it out. The majority of people are still putting implants in. They're replacing it, even if it ruptures. The mammogram is not the best test for rupture, but it's the cheapest and it's the easiest to be done. And MRI is the best test for breast implant leakage, but it's an expensive test, and a lot of times insurance will not pay for it, so they have to pay out of pocket. Now, honestly, even MRIs, I had patients who had negative MRIs and they still had a ruptured implant. So I tell people, if you have a 20-year-old implant, I think it's time to change it. You know, whether you get an MRI or not, it doesn't matter. It's just time for it to be changed. It's probably going to be ruptured or it will rupture. Or sometimes it's not a complete rupture, it's something called a gel bleed, which is basically the silicone starts going through the shell of the implant, but it's not completely destroyed, which means it will rupture one day. So I think common sense is important also, not in order not to abuse the healthcare system and do unnecessary studies. If someone is getting a mammogram or an ultrasound or an MRI for a different reason, great. Then we look at the implant as well, right? See what the situation.
Yeah, it's so. I remember I had a girlfriend many years ago who had A cup her whole life. And she decided she wanted to have that done. And it changed her as a person. She got so much more confident. She felt for the first time as a true woman, as she imagined as a girl growing up to be as an adult, which obviously part of it, like you said, is trauma or psychological, but it really fulfilled her. And so I can only imagine what it must be like to go the other way. What about breast reduction? Because I hear, the weight on the back, they're having to carry, as men, we can put on backpacks and carry things and take them off. Is that a pretty big occurrence with women?
It definitely is. And in some of these cases, they have actual issues like real neck problems, real shoulder problems. They already went to the chiropractor, they had non-surgical treatments, and it has to make sense, right? If someone comes in and they're H size or G size and the breast goes down close to their knees, guess what? I mean, that's a heavy breast, and that's going to cause a problem, and it's not a good thing. The problem happens is when this happens in early age, and there's something called virginal hypertrophy of the breast, where patients who are in their 15-year-olds, and I've seen 13-year-olds having a virginal hypertrophy, very, very large breast. Now, from one end, you don't want to do surgery on a 13-year-old if you can, right? But at the same time, it's causing symptoms. So it actually becomes a medical problem. And that's why insurance company actually covers it, because it's not a cosmetic issue anymore. This is real medical. This is something that can cause problem in your spine, shoulders, pain, all these things. So yeah, that's important. Some people only need a lift, which means their breast is just saggy, but it's not very big. That is not covered by insurance. That's not a medical issue. That's a cosmetic issue.
How tough is that then for reshaping the breast to be able to make sure that if you've had the skin, obviously that's been stretched, you've got this extra, if I use the word feeling, I don't want to come across sounding ignorant or also misogynistic. Is it possible to still keep the breast looking natural and something that a woman is proud of when she's obviously reducing?
To a great extent, for sure. I mean, people come and do this. And first thing we say when we see them in consults, like, remember, when you do breast surgery, you have to be ready for scars, because a breast reduction or breast lift means you're going to have scars on your breast. And 99% of people are okay with it because they're doing it for a reason. They're doing it because that is not a good shape. This is not something they're proud of. And sometimes having a scar that you can hide easily is better than having a shape that you don't like. So most people are totally okay to have that. Is it tough? Yes, it is. So a friend of mine what he's saying, he says that the problem with the breast is it's a three-dimensional structure and there are two of them. And the problem of having two of them is you got to keep them symmetric. So it's not like you're doing one and you're done. No, you have to match the other side. And we have another saying in plastic surgery, they're sisters, they're not twins. So no one is 100% symmetric. Even my face and your face. If you draw a line in the middle of our faces, your right eye does not look like your left eye. And we always go through that exercise, and it helps a lot.
Yeah, fascinating. Okay, so this is a topic I never even thought I'd go here, but it's so fascinating, and I'm sure people out there are fascinated as well. I don't judge people as to who they are, how they feel, how they perceive themselves in life, or who they really are. But I see a lot of male to female trans gender changes going on where they're getting breast implants. Obviously, that's how they feel, and that's what they, fulfills their reality. Again, no judgment. How does that impact what is a man's body in reality when you look at the chest plate and all the bone? Do they end up with the same issues that cis women would have when it comes to the implants? Have you worked in that field yet?
We don't do a lot of these, but it is a very complex issue because it deals with a lot of things, hormonal, psychological, human behavior. It's a very complex, and I know that some practices focuses on it. We don't focus on it that much, but it is a big. Back in the days, we've done some surgeries of transfer, basically of male to female and female to male, but they came with a lot of medical background. I mean, you had to have authorities, you have to have a psychology approval with it, you have to have the patient very well evaluated, and so it's a very complex topic. Endocrinology have to be involved because you want to make sure you make the right decision for that patient. You make sure they're psychologically ready for that change. It's a big change. You're changing your life completely, and it's not to be taken lightly for sure. Yep.
What's the biological impact?
You're becoming someone else. And we have stories after stories about this. And again, the thing you have to evaluate is, and that's based on something in the past, I don't do this now, is the person wanting the change gonna be okay with the change in the future? Or they're gonna come back and says, I didn't want to do that, or this is not what I wanted, things like that. And I've seen situations like this. And it's difficult, right? Because some of these surgeries are not reversible. You just cannot change and go back. So you got to evaluate it well. You got to make sure you're doing the right decision for them. And that's where it's a teamwork. It's not an evaluation by one person. It's not just a plastic surgeon. Actually, plastic surgeon is probably the last one. And this has to come from many, many different levels with a lot of medical good inputs, basically.
Yeah, it's so, again, for someone like myself as a layman, and I've got trans friends that are beautiful people, that I just wonder, a man with the flat chest and the skin and the stretching. I remember again with my, ex-girlfriend going from an A cup to a C cup, the stretching, the pain going through. But there was a question that I want to go back to that I wanted to ask. What does it look like on a mammogram or an MRI when you look at a leakage, when it's detectable, obviously, or in there? Is it inflammation in the body that's coming up? Do you actually see bleed of the fluid? How would someone identify that?
So if you like pasta, there's a sign called linguini sign. So basically, when you look at it, it looks like pasta inside the breast, and it's not pasta. It's just basically you seeing the folds in the breast, and a lot of times that could mean that it's ruptured. Now, there is a frank rupture, which is basically you see your implant, and then you see a hole in the implant, and then something coming out of it. That is a frank rupture, so that's easy to see. And then sometimes there are ruptures that you're not sure whether this is a fold or a rupture. And a lot of times the MRI report, even the MRI report sometimes says possible rupture. They don't say it's ruptured. They said maybe it's ruptured. And again, if your implant is too old, it's probably need to be changed, whether the MRI said it's ruptured or not. If you have a 5-year-old or 10-year-old implant, you're probably going to be fine most of the time.
I'm going to jump off of this. We spent a lot of time on this one, but again, it's fascinating because I don't know nothing in here. But let's talk about your charity over in Egypt. I was fortunate enough to witness the event that you held this, I think it was actually last year now. I think about it. Was it February? It's there. It was a fantastic environment. You work with the biggest hospital over in Egypt. And I should say this is with Cancer Hospital, correct? With children, and the donations go to families that don't have the funds, and everything's paid for the family to be there with the child to go through it. How did that start? Tell me the impact that it's having, because I know it's so passionate to your heart.
Thank you. And thank you so much for being there. Your presence and Vivian was amazing, and you guys really helped us a lot. Appreciate that. So this has a very long story. To summarize it is that when I was doing my rotations, I ended up doing a rotation in pediatric plastic surgery back home many, many years ago. And it was one of these things that it was just not meant at that time. And I didn't understand why I did it. But I built some relationships at that time with the oncology people, the pediatric cancer people, and things like that. And then at one point, my own mother had cancer, had kidney cancer. And then I was traveling back and forth. And then I met them. They came, they met me. We went to dinner, and they said, we want to do a charity to support, like a worldwide charity to support cancer, especially pediatric cancer. Would you be interested? And of course, it was the perfect timing because I had a family member very close to me that had cancer, and how can I help, right? And a lot of times people talk to you about things that never get done. But it was the right moment with the right people, and it just was meant to be. And we launched it back in 2008, and it was incredible. Like year after year after year. Now we are in all the major cities in America. We're in Canada. We just got approved in Switzerland, in Dubai, and we're working on England, by the way. So when we are approved in London, we should invite you to come and give a talk. So yeah, it grew. Wonderful people come in, and again, it supports major hospitals in the area. We support a lot of things in Egypt. We support a major hospital called 57 in Cairo, which is kind of the mother hospital in the whole area. We support projects in Africa and the Middle East, even in America. And again, it's growing. People love it, and it's been a blessing, to be honest with you. I'm very, very lucky that me and my family will be part of this.
And I've seen the stories of the impact it's had. You played a beautiful video of the children and the families that have been affected. I never do this in podcasts, but go ahead and tell people where they could donate, because I've seen it. This is real. This comes from it. So where could they go to learn more about your charity? And I say, if it's $1, we're $1 closer. It's not about the amount that you're donating. It's just the care that goes with that donation. The love that we feel is huge.
Thank you. Thank you so much. And yes, absolutely. Would love to support. So you can go on www.egyptcancernetwork.org or www.worldwidecancernetwork.org. And then there's multiple ways to donate and even support. Sometimes it's not money. Sometimes people with expertise, people who can be speakers, can come to our events, people who, there's so many ways, but just the support would be fantastic. Much appreciated. Thank you.
And how do people find out about coming to the event? It was a beautiful event. The energy in the room is incredible because again, I go back, your wife's beautiful, the whole family getting involved. It's more than a charity event. It's a family event. How would people find out about actually being able to attend?
So we're very blessed. Community in California is incredible, and people are giving, and people are kind, and they love it. So as you said, it became a community things with the kids even before, like the kids and their friends, they want to come and they want to volunteer, and then the parents they come, and then everyone comes. So obviously we have a big group of donors that we email them when there is an event. Um, it depends on, because we learned that we don't have tickets for our events. We don't take money for tickets. We don't tell people, hey, you have to pay this to attend. No, we don't do that. Everything is an invitation. And when you're invited, you know you're coming to a nonprofit, and you know you are expected to help somehow. It doesn't have to be money, but it could be something, right? And I can tell you, people are more than generous with their time, their energy, their money. And the biggest story we had is the first event in Southern California, who at the head of PIMCO at that time, Dr. Larian, who is now the president of Queen's College, and he's running for the chancellor of Cambridge University. Yeah, he became a good friend over the years, and he came to one of our events, and then was very impressed. He wrote a check, and then the guys came and showed me a number, and I told him, oh, there's an extra zero, and they said, no, there's no extra zero. This is the right number. It was $1 million, and it was like, wow, that was our one of our biggest moments, and it actually helped to take off the situation to a very different level. You know what I'm saying? Then once you start getting into the big numbers and people who are really believe in the cause, and he still support us a lot, and he's been speakers with us for many 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 years for now. So again, wonderful people. We're very lucky, and thank to you and Vivian too. You guys, your presence also makes all the difference.
That's very kind. I just want to just emphasize in there that when you say he gave $1 million, but I also know you say it's not about the money. I think what came with that $1 million was the endorsement, the belief, the trust in what you're doing is dynamic. It's not just a charity. It's not just a money haven for people to, have a tax deduction and I'll just give it somewhere. This is a real program that's making a difference around the world. And again, any family that has a child to suddenly wake up and find their child has cancer, or a family member, which is going to affect the child either way, it's beautiful. What's next for you? Because I know that as much as you have done so much, I also know you're driven to help people. That won't change. Where do you see yourself in the next 10 years? What are you learning? We got some great graduates coming out of university that are learning new stuff, technology. Where are you going?
So last year was an experimental year for me. So I traveled a lot. I was traveling pretty much international every 6 weeks, and I tried different things. So we have a partnership in England, actually, with an English group, a British group that have multiple clinics between Scotland and England. And we have a project in California that we do together. So that's very exciting. I went to Dubai and I did some work there. I'm still a consultant for the government of Dubai. So I go once a year at least to help out with their plastic surgery departments. We have a fellowship actually in the US here. So we have a program in the practice that has multiple levels of training. So we have high schoolers who come shadow, we have college students, we have medical students, we have residents, and we have fellows. And fellows are people who are actually plastic surgeons who finished all their training and they just need that extra step. So we have an endorsed fellowship by the American Society of Aesthetic Plastic Surgery. We've been having it since 2020. The next step for us would be growing the practice and bringing more people. So now I have two more partners that came on board. Dr. Lipu, who's an international figure in plastic surgery as well. He's joining us. And then Dr. Halim, who's another, you met, I think, Dr. Halim, and she's wonderful too. She's one of the great speakers in her field, and she's also joined our practice. So the future, I think, is growing what we do locally and internationally, continue the support for the nonprofits on many, many fronts. And then at one point, slowly, you got to learn when to pass the baton, right? And then see how you're going to do that and how you do it. I believe that surgeons should never retire. You should always be able to give something, but you got to be smart enough to also build the movement, you know what I'm saying? Build and prepare the next generation, bring in more people that 10 years from now will take over, or 5 years or 2 years, who knows, right? I think that should be the focus, hopefully in the next 10 years.
Do you think you'd ever be able to stop?
I don't want to. I've seen people who stop, like completely stop. They get sick. I mean, I've seen people who just, very, very busy, and then suddenly, okay, I'm gonna retire. I'm gonna travel around the world. It's like, okay, you're gonna travel for 6 months, and then what? You gotta keep yourself busy. I'm not saying plastic surgery. You could be maybe focused fully non-profit, right? Do things, but you gotta do something. You cannot just stay at home, watch TV. That is a killer in my mind. So we all should never do that in my mind.
Yeah, I have a thing that I have to say. The word retire rhymes with expire for a reason.
I
And
agree.
it's not maybe having to work as much, but it's certainly having the same passion that you had to have a purpose and feel important, feel validated because of what you're doing affecting other people most of the time.
100%. 100%.
Where can people find you?
Well, you can just put Dr. Seify, SEIFY.com, and you get all our contacts, all our things, websites, there's numbers there, Instagram. Interestingly, people now find us a lot on Instagram. It's becoming a great way of spreading the knowledge, which we kind of learned. It's not the old way of just reading a book. You gotta be on these platforms and do a good job educating. And if you're not, you're missing a lot. So we are on Instagram as well.
That's awesome. I just want to bring up something actually that you talk about with that, because I know we talked about Newport, where if I said it's your head office, it was your first office, and then you have a very prominent one in Santa Monica as well. We shared an amazing story about your staff in Santa Monica when the fires spread through Pacific Palisades. And I know it put a strain on your staff because a number of them were left homeless, living in their cars for a short time. There wasn't. How's everyone doing there? Tell me about that, that impact.
It's amazing. They're doing great. And I'm not going to mention the name, but one of our staff, you're right, did have to do that. And it was incredible. It was very tough. Luckily, no one was hurt. And luckily, they were able to return and everything. But what was impressive is that it came from them, actually. They came to me with the idea, and I said, yes, absolutely. They built a program to support the community and to give back, basically. I think everyone in LA did that at that time. And they managed to bounce back and did, extremely well. But we have a very resilient community, and I think that's one of the good things about it is that we get united more when we face adversity, and that I think make us better people every now and then. We don't want adversity, but guess what? It will happen, right? Just a matter of timing. And if it happens, it's better that we're together for sure.
And the one thing I know is they stay committed to their patients, even when they were suffering themselves. The care that your staff, and I know that you're so specific because it is about the client, their happiness, their comfort, because it's not just the surgery, it's not just a moment. It's the aftercare. It's like you said, walking down the street, seeing someone 10, 15 years later, and then feeling indebted to you. It stands out. Thank you so much for your time. It's been an honor and a pleasure to have you on here. I've learned so much today. It's fascinating. And that's why I love doing the Born Superhuman podcast, because we actually engage. It's not just reading. I love who you are, Dr. Hisham. Thank you so much, and love to your family and your staff.
Thank you so much. It's a great honor to be here, and always great to talk to you, whether on podcast or in person. And I hope to see you soon. Thank you for all what you do, by the way. Thank you.
Thank you so much.
Take care. Bye-bye.